Hi, and welcome to SpondyCast, where we bring together the best medical minds, thought leaders, scientists, patients, and caregivers to inform and inspire the spondylitis community. I'm your host, Jill Miller, living my best spa life, knowing that how we meet today has the power to change everything going forward. Hi, and welcome to SpondyCast. Our guest today is Dr. Mohammed Bittar. He is a rheumatologist and assistant professor of medicine at the University of Tennessee Health Science Center in Memphis. His main clinical and research interests are axial spondyloarthritis and psoriatic arthritis. He is a member of the Education Committee of Spartan, the Spondyloarthritis Research and Treatment Network, and is a member of ACES, which is the Assessment of Spondyloarthritis International Society, and GRAPPA, the Group for Research and Assessment of Psoriatic Arthritis and Psoriasis. Dr. Bittar, welcome and thank you. I'm so excited to have you today to talk about our topic of gender differences in axial spondyloarthritis.
Thank you so much, Jill, for the introduction, and thank you for having me. I'm very happy to be with you today.
Great. So this is a really important topic, gender differences in the disease. A common scenario I have heard many times and experienced is seeing a doctor or maybe a specialist and getting the response of women don't get AS. And that may come from a variety of different places. So I think we've made some advancements, which we'll talk about today, and I'm excited to dig into those. But can you start off with what are some of the main differences in disease characteristics between men and women when it comes to SPA?
That's an excellent question, and I think we can talk a lot about the subject because I'm very happy to be talking about this topic because, as you mentioned, this is a misconception that has been going on for a long time, for years and years, that if providers used to think that this condition only happened in males. That's why this condition was missed in a lot of females in the past. And what we are trying to do now in the spondyloarthritis community is to raise awareness that this condition happens in both males and females equally. So we will talk a little bit about epidemiology. Epidemiology, which is a study of frequency in the population frequency of conditions in the population. So in the past, they used to think that this condition, which is called ankylosing spondylitis, is much more common in males. So in very early studies, I think the ratio was 10 males to 1 female.
Wow.
And imagine. And then as medicine advanced, this ratio went down to 3 to 1. And we're still talking about ankylosing spondylitis, which is by definition, it's a radiographic disease, which means that we need to have some evidence of X-ray findings of inflammation of the sacroiliac joints. But as we advance in medicine, we know that it can take up to 10 years for this inflammation to appear on an X-ray. So thankfully, we have some like MRI or advanced imaging, so we can detect this disease earlier. And then we came to the era of non-radiographic axial spondyloarthritis, which is a spectrum of the condition, but where patients do not have an evidence of X-ray inflammation, evidence of sacroiliac joint inflammation on an X-ray. By introducing this term non-radiographic disease, this ratio became 1 to 1 between males and females. So imagine from 10 to 1 now to 1 to 1. So initially in the past, they used to think this disease or condition does not happen in females. But now we are trying to tell everyone that this condition happens equally in males and females because we do not want this to be missed.
That is fascinating. And that has really happened in the last decade and a half, right?
So from 3 to 1 to 1 to 1, it's within the past 2 decades. But the 10 to 1 to 1 to 1, 10 to 1 to 3 to 1, it was longer before. Anyways, the condition was not very well appreciated in the early 1900s or so on. So
right.
All of this happened within the past 40 to 50 years.
That's an amazing translation of research to practical use, isn't it?
Yeah.
Is there so when we go into it, so are there so the main differences you'd say between men and women in diagnosis tends to be around inflammation of the sacroiliac joint?
So actually, there are a lot of differences that we are trying to appreciate. And there are a lot of newer studies right now that are targeting this issue in specific about sex and gender differences between males and females in axial spondyloarthritis. Again, it's very important for us to understand those differences. Why are there differences? So we can appreciate how to go forward and doing studies or trials, whether it's treatment or diagnostic trials and so on. So we can try to uh, talk about different points about the differences in sex or its gender differences between males and females in axial spondyloarthritis. Clinical presentation is very important. So how patients present with symptoms initially to see a provider, there can be differences between males and females in how they present. For example, males usually present with lower back pain, inflammatory back pain. This is the most common type of picture. While recent studies have shown that females tend to have much more peripheral involvement. For example, they can start with having knee pain, ankle pain, shoulder pain, elbow pain. Those we call them peripheral joints before developing the inflammatory back pain. So by having peripheral joint symptoms, or also something called enthesitis. Enthesitis is like tendon inflammation or tendinitis. It's much more common in females compared to males. So if we are seeing a female patient who's coming more with peripheral involvement and not complaining of back symptoms, usually providers tend to think about other etiologies and try to think away from axial spondyloarthritis. And this is part of how this might be missed. Also, we can have to talk about the other manifestations of the condition that we see, such as eye inflammation, inflammation in the bowels, inflammation in the skin, psoriasis, and so on. Psoriasis and inflammatory bowel disease tend to be more common in females compared to males. The iritis or eye inflammation is around the same between males and females. So the clinical presentation can be a little bit different. And that's why we need to educate providers or the medical community that female patients with axial spondyloarthritis, they can present differently than males in the initial or early stages. So
Okay.
this,
Is there, this is a bit of a curveball maybe, but is there a prevailing misdiagnosis for females prior to getting a diagnosis of spondyloarthritis?
exactly, this is a very, very important point. Yes. So actually, you've heard about a condition called fibromyalgia. Fibromyalgia, it's a condition that can cause a lot of symptoms, a lot of pain symptoms, but it does not have the pathway of axial spondyloarthritis. Axial spondyloarthritis is more autoinflammatory pathway that involves, for example, the Th17 pathway or interleukin 17, Th17 cells, and so on. While fibromyalgia, it has a different pathogenesis that is non-inflammatory, or at least the current literature or current understanding of the disease, it's not inflammatory at this point. So because fibromyalgia can cause widespread pain and symptoms, females tend to be, or women tend to be misdiagnosed with fibromyalgia early on rather than axial spondyloarthritis. This because of different factors. One of the factors is, for example, widespread pain. There's an entity called widespread pain, which means there is pain at a lot of different parts of the body. This is more common in females compared to males. In axial spondyloarthritis patients, for example, 25% of female patients with axial spondyloarthritis, they tend to have widespread pain, while it's less common in males. So if the provider, whether it was a primary provider or whether a specialist like a rheumatologist, seeing patient for the first time and this patient is reported widespread pain, there is misdiagnosis that's happening towards fibromyalgia without trying to see if there's anything else going on like axial spondyloarthritis. We have to acknowledge that fibromyalgia can happen hand in hand with axial spondyloarthritis or with any rheumatologic disease, but we do not want to immediately label a patient as fibromyalgia without trying to rule out other etiologies. So the first thing we do in the clinic is we say, if we get a consult, rule out, for example, fibromyalgia or rule out axial spondyloarthritis. Fibromyalgia is a diagnosis of exclusion, which means at this point in time, we do not have a blood marker or anything in specific to tell you to confirm it on any of the tests. That's why we need to have a differential diagnosis. We need to rule out other conditions such as axial spondyloarthritis, ankylosing spondylitis, or different conditions before we label this as primary fibromyalgia.
Interesting. You just went through several years of my life as I was on my own journey. And I know it's highly frustrating for a lot of people who end up with an eventual axial spondyloarthritis diagnosis. And it's great information, right? Even as the patient to advocate for themselves as they're going through the journey to understand those differences. One of the things we talk about a lot is the age difference between men and women at onset. Is there a defined or understood difference in age when symptoms begin?
So the data that we have at this point, of course, we have data from different cohorts, whether in the US or whether in Europe or different parts of the world. The data that we have is that female patients tend to be diagnosed at an older age compared to males. This, of course, there's many theories behind that, but one of the more common things that we think about is because of the delay in diagnosis.
Yes.
Because if this condition is not captured early, or if providers do not think about this condition early on, this is most likely why the condition is being diagnosed at a later age in females compared to males. And actually, there are, I have to tell you that the delay in diagnosis is a very sad thing that we are trying actively in the spondyloarthritis community to try to close this gap by educating providers and medical community about the condition. So the average delay in diagnosis is around 6.7 years in the general population, but in females, it's even more. In female, it's around 8.8 years or 9 years compared to 6.5 years in males. So you have an extra 2 to 3 years of delay in diagnosis in females, most likely because of the lack of awareness that this condition can happen in females as well as in males.
Wow.
And I know you mentioned that you were frustrated, and I shared with you this frustration. And of course, this delay in diagnosis bring with it a lot of disease burden on patients. The condition can be debilitating. It can cause a lot of symptoms. It can cause what we call a loss of work productivity because of symptoms and so on. It can cause even a lot of psychological burden, such as depression, anxiety, and so on. So definitely this frustration is very well understood, and I share it with you, and that's why we need to do anything we can as a medical community to try to close this gap and to prevent this delay from happening.
I wholeheartedly agree. And it's probably the number one reason I became involved with the community. I saw it over and over, people having the same story. It was like we could have all written the same book. So not that men don't have a tough time getting diagnosed too. So I want to honor that. One question, I guess, is in follow-up, does disease progression begin sooner in women or men? Or is there clear data on that?
I don't think we have a clear data on this point. Again, this subject of sex differences or gender differences is relatively new. That is being studied within the past 3 to 5 years, I would say. So we do not have a lot of data on when does this progression start, but we have data on radiographic progression of the disease. By saying radiographic progression, it means we mean immediately X-ray progression. MRI, I want you to think about MRI as an image that can show us early evidence of inflammation. Of course, it can show us bone changes and erosions and bone damages and so on. But the MRI, we like to use it to assess for inflammation and evidence of active inflammation. The thing that will show us if this condition is progressing radiographically is an X-ray. For example, if we get an X-ray on baseline, day one of whenever we see the patient first time, and then we get another X-ray in 2 or 4 years after we see the patient, if patients are not getting the treatment, which I hope everyone will be getting treatment as early as possible, but if patients go unnoticed, the disease go unnoticed, underdiagnosed, and then there is a repeat X-ray after a few years, you might see changes in the bone, something called syndesmophytes, which is an extra bone formation, or even some patients in severe cases, they can lead to something called bamboo spine, where the spine can get fused. So those are progression of bone that you can see on an X-ray.
Okay.
This progression on a radiographic progression, we have some data on it. It's more in males compared to females. So the radiographic progression can be seen more in males. That's why the prevalence in males it was thought to be more in males than ankylosing spondylitis, because it's a radiographic entity. But why does this happen? Of course, we need more data on it. One of the theories is because of a genetic marker I'm sure you've heard of. It's called HLA-B27.
Yes.
We'll talk about it more because I always like to talk about HLA-B27. But HLA-B27 tend to be more common in males compared to females. And there are some studies that have shown that HLA-B27 can lead more to, or can be associated with more radiographic progression or radiographic disease. So, and this is again important to talk about because females can have less prevalence of HLA-B27. So we do not rely on the presence of HLA-B27 to make a diagnosis. So if there is a patient, whether male or female, have negative HLA-B27, that does not rule out a condition. So this is again a very important thing that we talk about, because we do not want to miss a condition because a patient does not have an HLA-B27. And this is more in females because they have less prevalence of this genetic marker.
Yeah, and I've heard a little bit in terms of tracking disease progression, more so in females, using ultrasound to watch enthesitis change over time and how that contributes. So there are, and I think these are newer advancements in the last couple decades, which is wonderful.
Regarding just one point regarding the ultrasound, I agree with what you mentioned. There is more studies being done on ultrasound right now, but it's being done more in psoriatic arthritis.
Okay.
And then it will hopefully move toward ankylosing or axial spondyloarthritis. There's a lot of overlap between psoriatic arthritis and axial spondyloarthritis because they belong to the family of spondyloarthritis. But I agree with you that this is something that is being looked at very recently on ultrasound in the condition.
Interesting. And so we have come a long way from identifying AS as a man's disease. Is there anything that stands out in the past 10 years that's made the changes possible and assisted more women in getting diagnosed? Or is it the human factor in the diagnosis that the rheumatologist uses?
So that's a very important question. I think the main thing is, of course, we have great researchers working on in this field, and all these questions that we try to bring up, those are very important questions. But the thing is, we always heard that this disease is disease of males. Even in medical exams, when we are taking medical exam, They usually give us a scenario, like a clinical scenario. For example, and always it was a 30-year-old male. Maybe it was 30, 30, 35, 25, but it was always in the medical exams, it's a male who has this condition. And now what we are trying to do is, if we are in a conference or so, we're changing the clinical scenario to include this is a female who has this condition, because we want to tell people that this condition happens in females. But the main thing is that because in the clinic, in the clinical setting, we are seeing a lot of females who have this condition. And a big percentage, or in a certain number, like percentage of these females have radiographic progression and have radiographic evidence of the disease, so they can have a bamboo spine. So by seeing these cases in the clinic, you cannot deny that this condition happen in females. So I think when the clinicians started seeing this case in the clinic, probably those questions came up, that why we always thought that it's disease of male and so on, and that's how the research started. But also there is a lot with the advancement of research. We have acknowledged there are a lot of differences between males and females in axial spondyloarthritis. If we have some time, I'm happy to talk about those differences.
Absolutely. We would love to talk about those differences.
Perfect. So, for example, also the newer studies have shown genetic differences. I talked a little bit about HLA-B27, that is less common in females compared to males. There is another gene called ANKH. This gene can lead to more ankylosis or more radiographic disease, for example, progression of the disease. Studies have shown that the loci of this gene are different between males and females. Same for different genes that are newly being discovered, that have shown that, for example, if this gene is present, then the patient might not respond to treatment as we would like them to respond. So there are genetic differences that we need to acknowledge between males and females. The other thing is immunological differences. For example, sex hormones. Sex hormones are different between males and females, not only in axial spondyloarthritis, but in medicine in general. And for example, the presence of estrogen, some studies have shown that the presence of estrogen can lead more to production of inflammatory markers, such as tumor necrosis factor and so on. Also, there are studies have shown that Th17 responsive, those are inflammatory cells, and interleukin-17 cells can be more prevalent in men compared to women. Why do I say all these factors? Because when we understand that there are immunological differences between men and women, this will make us think that maybe the treatment responses might not be the same with the same medication. And for example, if I see a female or a woman who did not respond to this medication, maybe I shouldn't say that this patient does not have the disease, but maybe the immunologic print of the genetics of this patient is different from the other one. That's why they are not responding. So there are differences, genetics and the immunologic immune system between men and women. Also, yeah.
Is there, I can let you come back to that, but is there also differences that occur within women of childbearing age or women in pregnancy? I know a number of people who had very different symptoms during their pregnancy, or a lot of flaring, or for some it was better during different periods of the pregnancy. So is there a general understanding of what goes on during pregnancy for women?
Yes. So again, this, of course, all your questions are very, very important questions. This pregnancy, axial spondyloarthritis in pregnancy, this topic is not very well understood. We have newer data. We have some ongoing studies in the spondyloarthritis community about what happens in pregnancy for axial spondyloarthritis patients. We know in rheumatoid arthritis, for example, it tends to get better. The condition tends to get better in pregnancy. We know in psoriatic arthritis, it's similar. It tends to follow a pattern of rheumatoid arthritis. But in axial spondyloarthritis, we do not have a clear pattern. As you mentioned, that there are different people tell you different things.
Sure.
But what we think, what again, there is no pattern, but what we think is that the condition might remain active within the first 1 or 2 trimesters, and then it tends to get a little bit better toward the third trimester. Why does it happen? Again, it could be related to hormonal changes in pregnancy, but again, we do not have like a clear-cut answer at this point because we need more data. What happens after delivery? It varies between patient and another. We do not have a similar one pattern for everyone. One thing I want you to keep in mind is that pregnancy, there is a lot of weight load on the pelvis in pregnancy. And this can cause symptoms on its own, even if this is not coming from an inflammatory source. For example, if you have a female patient, pregnant patient, pregnant person, not another thing, because if they do not have the condition, if they do not have axial spondyloarthritis, they might develop some low back pain toward the end of pregnancy because of the weight they are carrying, because of the pregnancy. So this stress on the pelvis can cause some symptoms as well. This can be a confounding factor because we can't really tell if the symptom is coming truly from inflammation or from the weight of pregnancy. One thing I want you also to know, this is very interesting finding that has been shared with us recently in the literature about if we see a patient after delivery complaining of back pain, and if we get an MRI of the pelvis within the first 1 or 2 months after delivery, we might see a lot of what we call bone marrow edema or inflammatory changes in the pelvis or the sacroiliac joint immediately after delivery. And actually, there's a very interesting study that was done. I forgot the number of patients that were enrolled, but they started with a number of patients. Immediately after delivery, they did an MRI of the pelvis. And then 6 months after, and then 1 year after delivery, they followed them and then they repeated the MRI 6 months and 1 year after. Immediately after delivery, a large percentage of those patients had inflammatory changes on the MRI that looked like axial spondyloarthritis or ankylosing spondylitis. They repeated this 6 months after, this percentage went down. And by 1 year after delivery, this percentage went down to 12%, which is much lower than the percentage they started with. So pregnancy and the weight of pregnancy can lead to stress on the pelvis, which can lead to those changes in the SI joints, sacroiliac joints. That's why we need to know also how to interpret those changes in MRI after delivery, because again, I know there's a lot of underdiagnosis in axial spondyloarthritis, but also we do not want a misdiagnosis or overdiagnosis of the disease because of a misinterpretation of the MRI. So that's why axial spondyloarthritis in pregnancy need to be studied more because we need more data on it.
That's really interesting. And again, with both my pregnancies, I was in constant physical therapy. They couldn't figure it out. They said, go get an MRI after you have the baby. And by the time I got there was nothing, right? So that's my own experience. I don't know about anybody else, but I know that it can be very challenging. And at that time, I had never even heard of ankylosing spondylitis. So we talked a little bit about genetic predispositions to AXPA in men and women. Related to that, what are the main differences in treatment approaches for men versus women? Is there a protocol based on gender, or is it still very high level based on the overall picture?
At this point in time, we do not have a protocol based on gender or sex. It's the same approach for both men and women. Why? Because the clinical trials that were done of the different medications in this condition. They were not stratified based on sex, or what, let me rephrase it, they were not powered. Usually, we need, when we do a clinical trial or a study, we need to have a sample size or a power for the study to detect a difference between two things we're studying. For example, if we want to appreciate a difference between men and women, we need to have a specific power of the study in order to be able to tell us if there's a true difference between men and women or not. Sadly, unfortunately, the trials that were done in the past were not powered to detect this difference. So right now, we cannot really stratify treatment based on sex or gender. In the future, we hope to see more power analyses to try to differentiate between what treatment works for what sex or what gender. But at this point in time, we do not. At this point in time, we have a clear algorithm. For example, we follow in the United States, we follow the ACR, American College of Rheumatology, Spartan, and the SAA guidelines that were last published in 2019. This guideline, we have an algorithm. First line treatment is anti-inflammatory NSAIDs, of course, in the absence of any contraindication to that. And then the second line will be a TNF inhibitor, tumor necrosis factor inhibitor. And then after that, it will be interleukin 17 inhibitor and the newer class of medication that was added, which is Janus kinase inhibitors. So really, how we choose a treatment at this point, it depends on individualized choices. So it's the patient that we see, what comorbidities they have, what other medical conditions, what contraindications they have, what other manifestations of the condition they have, and based on that, we talk to the patients about what options we have, and then we proceed with that option. But we do not have an algorithm based on sex or gender.
Okay. And in the spirit of inclusion and access to healthcare, I would hope that clinical trials in the future will include women, a bigger population of women, and maybe some other ethnicities. So as we get further in research, yeah, that's fantastic. Does ethnicity or nationality that we're aware of have a correlation with the number of men or women diagnosed?
Again, this is an excellent question, but I don't think I have an answer to it, mainly because, as you know, which you mentioned something very important, we hope that we see more women in the trials in the future. We need more representation of women and different races or ethnicities. There is a study that was published from a registry from the US about sex differences in axial spondyloarthritis, and the number of females who were not white or not Caucasians were very minimal, very, very small number. If I'm not mistaken, it was less than 10. And in statistical studies, epidemiologic studies, you cannot make conclusion if you do not have a good number or a good sample size. So that's why I don't think we can answer this question, because we do not have data on it. I think we need more data.
I would agree with you there. My head is spinning with research ideas.
That's amazing. We always want research ideas. Please let us know. Honestly, you cannot imagine how much you can help us by telling us those ideas. Maybe we can work on them in the future.
Yeah, because I would think if we're not including, right, we've already got the lack of inclusion of females, and then when we're looking at white females, that's one area, and then when we're looking at the underrepresented groups within females, there are a whole host of other problems that may be preventing diagnosis, just lack of access to healthcare, social determinants of health, all these different things. So you guys can cut that if you need to, but I'm passionate.
But I agree with you. This, I think, needs a different session about about racial and ethnic disparities, because this is something that I like to talk about a lot as well, because we need to raise awareness about the subject. And I think it needs a full session about the disparities in axial spondyloarthritis that I'm more than happy to talk about in a different session, definitely.
Excellent. So I think the one question too that we covered a little bit, but I think it's important, is what are the major differences in comorbidities in men and women, or are we still do we still have a question mark there? I know, when it comes to cardiovascular or different risks.
So we have two things. We have manifestations of the disease and we have comorbidities. Manifestations, as I mentioned, is what other inflammatory features that happen with the disease, such as eye inflammation, skin inflammation, inflammatory bowel disease, and so on. Inflammatory bowel disease and psoriasis tend to be more common in female patients who have axial spondyloarthritis. Uveitis or iritis, eye inflammation, it's around the same prevalence between male and females. When it comes to comorbidities, it's increased in both. I think from the registry that we've seen in the US, it showed that both men and women have increased risk of osteoporosis, osteopenia, or low bone density, and so on. Both men and postmenopausal women have as if I remember correctly, it's postmenopausal women have higher risk of having cardiovascular events, cardiovascular heart problems. Those are the main comorbidities I think that were addressed in this registry. But is it more in men compared to women? I think we need, or more common in women compared to men. We need more studies on that. But at this point, we know that those comorbidities are increased in both genders, both men and women. And that's why we need to catch the condition early in both sexes so we can prevent those comorbidities to happen as much as possible.
Absolutely. It's almost like design principles. Designing early, designing out the variables early reduces your rate of failure, right? So this has been fascinating. We're going to wrap up, but one question I have for you, and it's a two-part question. You can pick to answer one or the other, is number one, what are your top 3 tips for any patient with the disease? And number 2, what do you find is most hopeful about progress for this community coming in the future?
I would love to answer both questions. The first one is what tips I have. The main tip that I have, and I say this to every patient with axial spondyloarthritis that I see, is I want my patients or axial spondyloarthritis patients to think that they can achieve anything they want in life. And I do not want them to think that this condition can limit them in achieving their dreams or goals in life. This condition can cause symptoms, and this condition can cause, as I mentioned, pain. It can cause different types of conditions. That's why the patients will need to work closely with their physician to try to control those symptoms. But these symptoms should not in any possible way hinder the advancement of the patients in their career or in their life. Every time I talk to my patients, I was like, you can be very productive in this society. You can be anything you want. You can be a CEO of a company. You can be anything, the top position of anything you want, because my patients, or the expat patients, are very smart, very hard workers, and we can learn how to cope with this condition, how to not say, why did we get this condition? I don't think we should say this. Why us? Why not anyone else? No. If we get it, we need to embrace it. We need to work with our physician to control the symptoms, because the second question that you asked, because the advancements that happen in this condition are a lot, especially over the past 20 years, over the past 2 decades. We advanced from having no medications, basically nothing except other than NSAIDs, to having at least 3 or 4 classes of medications like TNF inhibitors, interleukin 17 inhibitors, Janus kinase inhibitors, and we have a lot of other targets that are being currently studied in the literature. So there have been a lot of advancement in this field. These medications have shown that, of course, we can't say in everyone, but they, in a big percentage of the portion of patients, have caused a lot of relief. It helped a lot with symptoms. It helped with progression, with lowering the progression of the condition, and with preventing comorbidities from happening or preventing complications from happening. So we have a lot of advancements that have caused a lot of relief in a lot of patients. That's why we want to work very closely with AxSpA patients, and I want them to know that we will try anything in our power to help them, but I want them to believe in it, because we need to work both together on achieving the goal.
And there is tons of great research, and it's translating into outcomes, right, and impacts.
Exactly. There are a lot of research happening on targets of treatment, which is very promising for the future. It's always good to have more targets. Hopefully, we would like to see personalized, targeted medicine. This is not something that's happening in rheumatology, or at least I'm not going to say, let me rephrase it. This is not the case in rheumatology right now, but hopefully the ongoing studies or the future studies will lead us to this precision medicine in rheumatology, where we can say that we have this patient, then maybe we can choose this type of specific treatment for them, because we will know ahead of time what will work for them or what not. Hopefully we'll reach this stage in the future. Also, there's a lot of work happening on the causes of this disease, such as pathogenesis. Again, it's very important for us to understand the causes of the condition so we can understand how to target this condition.
Excellent. Dr. Bittar, thank you so much for this time. This has been a great conversation, and thank you for your commitment to the community. It's much appreciated.
Thank you. Thank you so much for having me. It's been a great pleasure. And as I mentioned before, this is my passion, and rheumatology is axial spondyloarthritis. So I will continue to work with the community on different aspects to try to raise awareness about the condition and to try to combat this condition, because I want hopefully every AxSpA patient to be diagnosed as early as possible and for them to get the help they need as early as possible. Thank you so much for having me, and I look forward to future collaborations.
SpondyCast was made possible by donations from the Spondylitis Association of America's individual members and our show's corporate sponsor, AbbVie. Since our founding in 1983, the Spondylitis Association of America has been the face, voice, and leading nationwide nonprofit educating, empowering, and advocating for people living with spondyloarthritis. Through our extensive work with patients, the medical community, and partners, we provide information and resources to help people impacted by the disease live better lives and champion research to find a cure.